Good afternoon and welcome to everyone. This is the first Wellbeing of Women webinar for 2023, and it's a great pleasure to be sharing with you the fact we're going to explore how we can prevent cervical cancer, and we've chosen it this week because we're coinciding with Cervical Cancer Prevention Week globally. Now, we know that there are nearly 3,200 new cases of cervical cancer every year just in this country. It's a cancer that's found anywhere in the cervix, and we're going to discuss the anatomy in a moment. It's the opening between the vagina and the womb. And we also know that cervical screening is highly effective, and it has the potential to prevent about 70% of cervical cancer deaths. So the question that we're posing here is, what can we do to protect ourselves from this cancer? And I'm joined by three wonderful guests. Ms Theresa Freeman-Wang, who's a consultant gynaecologist at the Whittington Hospital NHS Trust, where she's the lead for gynaecology oncology or cancer services. And I'm also joined by Hannah Dwyer, a support services officer for Joe's Cervical Cancer Trust, which is the UK's leading cervical cancer charity. And thirdly, by Dr Maria Paraskevaidi, who is a research fellow, as you can see from her screen, at Imperial College London, and whom we're very proud to say we've recently funded to undertake a fellowship to look at ways to improve screening. But I'm not going to take the limelight from any of those individuals because they're going to tell you in their own words what they're going to contribute. So my name is Lesley Regan, and I'm the chair of Wellbeing of Women. I'm still practicing gynaecologist at Imperial. And I just wanted to remind everybody who's attending on the platform today that Wellbeing of Women, or WOW, as we shorten it to, is the only UK charity which is funding research and education and advocacy right across the life course of women, from cradle to grave, or as somebody jokingly said to me the other day, from womb to tomb. So I'm going to start now, and I think we're going to start with Theresa, because she's going to give us a bit of a background to how big this problem is, not just in the UK, but globally. And I think that's really important because what we achieve in the UK is often emulated or copied elsewhere. So we have not just a responsibility to improve well-being of to improve the health of women and prevent cervical cancer in the UK, but this will actually have global reach. And I think that's really, really important. So Theresa, can I start by asking you to explain to our audience, what is cervical cancer?
Yes, so thank you for the invitation, and to all of the people that are there. So cervical cancer, if I show you perhaps a picture, is a cancer of the neck of the womb. And as you quite rightly point out, it's entirely preventable. And part of the WHO, I don't know whether you can see that. So the image there is just showing, so this where my arrow is, so if this is the vagina, the cervix as the neck of the womb juts into the vagina, and you can see that it really is an important organ because it's allowing the flow of fluids between the womb and the vagina. So when women have periods, it's producing a mucus plug, which is important in terms of fertility and protecting pregnancy. It dilates during pregnancy to facilitate the birth of a child, and it's the site where these cancers arise. And part of the thing that you were asking, so this is what a cervix looks like in real life, and you can see there's a cotton bud there, so that gives you an idea of how much the picture is magnified. And that picture is really showing clear mucus, so that's showing a cervix that is ovulating. So that's the issue there, and this gives an overview of cancers around the world. And what you can see there is that although in this country, because we have an effective screening program, there are very few cancers, as you already pointed out, but worldwide, it's still one of the biggest killers of women, and more so these days than maternal mortality. And it's a reflection of countries that don't have screening that have the highest rates, and sub-Saharan Africa and also in countries where HIV is endemic, because cervical cancer is an AIDS-defining illness.
Thank you very much, Theresa. That's a great start, as I'm sure everyone will realise. And I think it's really important to emphasise how when you get governments and policymakers and healthcare professionals to focus on a problem, that's when you get change in outcomes in healthcare for women. And there's been a global drive, not just the UK drive, to reduce maternal mortality, which is not perfect, but it's a lot better than it was. And it's so sad now to see that a disease which is entirely preventable with HPV screening and also further cytology and colposcopy treatments has actually now, not only is it not reducing, but it's actually increasing in prevalence. And as you rightly say, Theresa, it's now overtaken maternal mortality, which is really, really shocking. And I know that some time I've spent in South Africa, which is one of those endemic countries in terms of HIV prevalence, seeing some of those very, very young women with very advanced cervical cancers who had no treatment at all because there was no radiotherapy or anything like that, and actually also very little analgesia. And it's quite terrifying to see. So we do have a real responsibility, I think, to try and make this something that everybody understands the importance of and what they can do to help themselves. So can I turn now to Hannah and ask her to tell our audience, please, about what the symptoms are. So starting with the common ones and then going on to less common ones. What should our audience be concerned about and what should they be looking out for?
I thank you for having me. As Lesley said, I work for Joe's Cervical Cancer Trust in our services team. So we get lots of calls to our helpline and frontline services about when people should go for screening, what they should be looking out for. I think what's really important is that screening isn't a diagnostic tool. So if somebody has got symptoms, that going to see a healthcare professional would be something we'd be advising to do from the outset. But things that they could be looking out for is pain after sex or irregular bleeding that's not in line with their own body, you know, outside of their menstrual cycles, things like that, lower back pain, some of the common symptoms, but obviously they can be attributed to other health conditions, so it might not just be linked to the cervix. So I think the important message from us at Joe's is, whilst keep an eye out for those symptoms, it's all about getting people to actually go to their screening and making sure that people feel comfortable to attend those appointments when they're called for them.
Thank you. And Theresa, any other thoughts that you can share with our audience about the symptoms?
Yes, well, the issue, as Hannah quite rightly points out, for most people, they may not have symptoms. So the function of screening is to detect pre-malignant disease and treat that before cancer develops. And the treatments are very simple, they're highly effective, and don't have very much sort of side effects or problems overall. So that's the most important thing. But even if you go for your screen test and you have symptoms, so for example, if you experience bleeding after having sex, if you're, and that's a repeated thing, then clearly the first thing to do is to check that there isn't infection. But if that isn't the case, then that needs to be checked out. If women are having irregular bleeding, particularly bleeding in between the periods that has no pattern at all and persisting, again, that needs to be highlighted to the GP and onwardly referred. So those things shouldn't be ignored. And one of the problems, particularly in young women, is because those things are actually quite common and invariably related to being on a type of contraceptive pill that needs changing, they may be ignored. So the important thing is not to ignore them, to speak to a health professional and just to get it assessed. It takes 5 minutes to be examined, and that can make a big difference.
Thank you. So really important messages. Yes, there are some symptoms and two of our speakers have flagged those up, but remember that many times it's asymptomatic, and that's why we've got this screening program that starts at 25 and then goes on. So Theresa, would you like to just tell us a little bit about the screening program and what that involves?
Yeah, so in the United Kingdom, we have 4 nations. And the program in each of the nations is very slightly different. But overall, from the age of 25 to 65, we invite women to attend for a screen test. And in England, Wales, and Scotland, that test is testing for the virus that we know is necessary to be present if an abnormality is going to arise. So that's an HPV, or human papilloma virus test. So the test itself is exactly the same as when women used to attend for their smear test, but when it goes to the lab, they're looking for the presence of this virus. At some point in our lives, virtually all of us will have the presence of that virus. So that doesn't automatically mean that you're going to have cancer. But if the virus is present, then at the lab, they will look to see, are there any abnormal cells? And in that circumstance, refer to for another screening test, which is called a colposcopy, where one can have a closer look at the cervix and perhaps take a small sample to check. So those, so that's the screening program broadly. Northern Ireland, because it's had no government for the last few years, is still on the old system. So, so it's slightly different if you live in Northern Ireland. And the other difference is if you're in Wales or in Scotland, you will be called for your screen test every 5 years. Whereas if you're in England, between the ages of 25 and 49, you'll be called every 3 years. And after 50, you'll be called every 5 years. And some people felt that that was because of cost implications and that they're getting a lesser service. That's not the case. It's purely that in England, our IT system is too old to change to the new system. So the Scottish and the Welsh have a newer system that makes it easier. But all the evidence across the world shows that if you get screened every 5 years with this particular test, because it's a better test, that that is very safe.
Great. So the messages here to our audience are that we've made great progress, and because we know that the vast majority, like 95% of cases of cervical cancer, are caused by the HPV virus, that's a wonderful screening test. And would you like to make a comment, Theresa, about the fact that in some areas of the country we're now developing self-sampling testing?
Yes, so there's good evidence that self-sampling, which means that you use a small swab and you insert that into the vagina, put it in a little vial and send it off in an envelope to the lab, works very well. There are some studies ongoing here in the UK. There's one called U-Screen. We're waiting for it to report, and hopefully that should report this year. And the question is whether at the moment, self-sampling is something that has been explored in the United Kingdom, mainly for those women who haven't been attending, to see if that encourages more people to come. But in Australia, it's already part of their program. So a woman can elect to have a self-sample test or a clinician-taken test within their program. And the hope is that within the next couple of years or so, that we can accommodate that in our program in this country. Thank you.
And Hannah, Theresa was talking about the women who don't attend. So I know that Joe's Cervical Cancer Trust hears a lot from women who've got these problems and feel that they've been sort of left behind or excluded from this. Can you tell us a little bit about the women that don't attend and emphasize how important it is to try and persuade them to come forward for screening?
Absolutely. I mean, we speak to lots of people that for various reasons feel they can't attend. There's lots of things that could be barriers, such as learning difficulties and disabilities, people that can't access screening. There might be cultural reasons why people don't feel that they can go. It could be down to feeling embarrassed, it being uncomfortable or painful for somebody to go. It could be that somebody's been through sexual violence, so going for a screening is just not something they feel comfortable doing. And we do hear a lot about that through our services. I would say there's lots of things that you can do to either help yourself or those around you who perhaps don't want to go to screening. We've got lots and lots of resources on our website about all of those things. We've got our helpline, which obviously anybody's welcome to call and ask for advice and support. You can speak to your healthcare professionals. There are lots of things that you can do to prepare if you do decide to take that step to go, even if you don't have any of those issues, but you're just worried about going, or you've been and it wasn't particularly comfortable and you're worried about the next one. There's still hints and tips that you can use on our website that they seem like really simple suggestions, but they're all there to try and encourage and help that appointment to be the best and most comfortable it can be. So things like booking a longer or double appointment with your screening nurse if possible, perhaps wearing a skirt or taking a blanket. Sometimes people find lying on their left side, which is a different position to have your smear taken, more comfortable. If you've got someone you can talk to, as in a friend or family member that could perhaps talk you through their experience. There are lots of things and ways that you can make that better. And I think our message is do reach out for support and do use those resources to enable you to go, because it's so important. And the test itself is relatively quick. Obviously, the actual run up to it might be longer for you if you want to talk it through. The actual smear itself is it's minutes long. So 4 minutes that can actually help prevent something happening. It's really important that you reach out if you are finding it difficult for whatever reason to go.
Thank you. And Theresa, would you like to share with our audience, you very helpfully said earlier that HPV doesn't always progress to cancers. And I want to emphasize that if you are HPV positive, it doesn't mean you've got cancer. It means that you could be at greater risk. And it's a great step forward, isn't it? Because it means that we can actually focus the attention and the more detailed follow-up on the women who are most likely to have a problem. But I think it would be really helpful for the audience to understand what sort of percentage of the HPV positive cases go on, and in contrast, what percentage of them resolve themselves, and so they don't need to be as worried as possibly they may be feeling at this moment.
Yeah, so as I mentioned, 80 to 90% of us, particularly during our reproductive years, will have HPV present at some point. On average, it takes about 18 months to up to 3 years to clear. And so within our program now, if a woman has the presence of HPV but no abnormal cells, the advice is that that test should be repeated a year later. And if after 3 consecutive tests, each a year apart, there has been the presence of HPV but no abnormal cells, then as a precaution, those women are still referred for a colposcopy examination just to check that the cervix and everything looks fine. But the vast majority of women will find that their cytology and their cervical screen test essentially will clear. Overall, there are about 10 to 15% of the population of women who will have persistence of their HPV. So that's something to do with their immune system, which says that they're not able to clear the HPV infection as other people are. So 85% of women are going to clear their virus and they may never know anything about it, and it's not going to cause any problem. And really, it's in that 15% that we see persistent changes, and those are the group that may need some further follow-up. So that's, I think, important to be aware of. So having HPV is common. Most of us will have it, most of us will clear it, and it's not going to cause us any issue. In terms of, I think I can't see the whole of the question, but it talks about the HPV vaccine. So in this country, we have had HPV vaccination in school ages since about 2009. And since 2019, we're also vaccinating boys. So girls and boys aged 12 to 13 are all offered the HPV vaccination. But one needs to be aware that that will cover many people, but it won't cover all of the HPV viruses. So it's important to try and promote vaccination, because that overall, there's lots of evidence from Australia, from Scotland, that shows by so doing, we reduce cervical precancerous changes and therefore cervical cancer. But it's not going to prevent all of it. So screening remains important. But in our country at the minute, what we will have is a cohort of young women coming in who've been vaccinated, who may still get an abnormality, and they'll be surprised by that. But it only covers against 70%. It doesn't cover everything, which is why it still is important to get screened. There'll be a cohort of women who have not been vaccinated, and there'll be a cohort of women who have had 1 or 2 of the vaccines, but maybe not finished the course. But there's evidence to show even if you have 1 vaccine of HPV, that is protective and is of value. And the only other thing to say, because I saw that in the chat, somebody was talking about menopausal and it being painful. If a person is menopausal and not on hormone replacement, then speaking to their GP and asking for some topical estrogen to use for about 3 weeks or 4 weeks before their test, ideally stopping at least a week before they actually go, because all you otherwise see is the cream, and then have the vaccine, then that, then have the test, it can be a lot more comfortable. And if it's still uncomfortable in, for example, a GP surgery setting, you can always ask to be referred up to the cytology service at any of our 26 colposcopy units around London, for example, or any in the country, because we've got smaller speculi and we've got a different chair that can make it a lot more or a lot less uncomfortable, put it that way.
That's really helpful, some really good tips. Now, Maria, can I come on to you, and can you tell us in very layperson speak exactly what your research is and why you're doing it?
Right. So first of all, I would like to thank the Wellbeing of Women for actually giving me this research postdoctoral fellowship. And we've heard from Theresa all about the current workflows from screening to diagnosing and treating cervical disease. However, it's also important to know that some clinical challenges still exist. So as Theresa said, women would be initially screened for the presence of a high-risk HPV infection. And if that screening test is positive, then the sample would be sent for further triage testing using cytological assessment under the microscope. So if that triage test also shows the presence of any abnormal cells, then the woman is referred for further colposcopy, where multiple biopsies might be required for a final diagnosis prior to being offered a local treatment at a separate visit. So it's quite evident that novel technologies are needed to offer a bedside diagnosis at one-stop clinics, which would actually minimize the risk of non-compliance and repeat visits. And moreover, also to say that it's quite important that surgical treatment is also accurate and complete, as recurrence rate after treatment can be as high as 40 to 50% for precancerous lesions. And because clearance of the surgical margins can be difficult to be determined with the human eye, this can lead to a further surgical removal at a second procedure. So when treating cancer, the need for an immediate result could actually enhance intraoperative decision-making. So during this Wellbeing of Women Fellowship, I will be using a recently developed platform that employs a technology that is called metabolomics for the detection of cervical precancer and cancer. So metabolomics is a field that actually studies small biomolecules that are present within a biological sample, and these are called metabolites. So the metabolites are the end products of the metabolic processes that are happening within the human body, and therefore they are thought to be representing more closely the pathophysiological processes that occur. So very simply put, in precancerous and cancerous states, there is a dysregulation of these metabolites, and therefore the metabolic profile from a person with cancer will be different from a profile of a healthy individual, and this could be used for diagnostic purposes. So the platform I will be using will allow the analysis of biological samples, such as cells and tissues in real time, which would actually make it a perfect tool for use within the colposcopy clinic or even the surgical theater. If you wanted me to go in a bit more detail,
no,
but
I think that's lovely. That's lovely. Thank you very much indeed.
Thank you.
So you're going to be undertaking this research, and we're delighted, Wellbeing of Women are delighted to be funding you, so that we're basically going to make the detection more sophisticated and more accurate, which is great. There are quite a few questions here about HPV vaccine, so I think that will be a good thing for us to address now. why isn't the HPV vaccine given to people of all ages?
The evidence isn't there. And the HPV vaccine is licensed up to the age of 45. And when one is looking at a vaccine and sort of the antibody level to show that it's effective, a single dose, as I mentioned, does give you more immunity than your natural immunity. Because the other thing to remember is that, as I said at the beginning, virtually all of us will be exposed to having HPV, and virtually all of us have an immune system that is good enough that's going to clear it, and therefore it's not going to be a problem. The vaccine gives us added protection, but is a prophylactic vaccine. It's not going to treat. So if you have an abnormality already, it isn't there to treat the presence of what you've got. It's trying to prevent you getting anything. So that's why it's best given before sexual activity in an ideal world. It is still shown to be effective, and in Australia, you can still get vaccinated up to the age of 36 on their national scheme. In this country, young people can get it. It's available in the private sector, but you have to pay for it. There's no evidence on a population base that by offering it to everybody, that it would make any significant difference.
That's really helpful. So that's the answer then to the question, as one of our attendees has said, I'm 46 and I had an abnormal smear where HPV was detected and the colposcopy showed that the cells didn't need removing. I'm waiting for the follow-up colposcopy a year later, but can I have the HPV vaccine now?
Well, for a 46-year-old, you're just over the age where it's licensed. So there will be occasions where women who are above that age will be offered the vaccine. And in fact, at Imperial and at the Whittington, we're part of the novel trial, so which is a trial looking at women who have had treatment or at the time of treatment are randomized to either be vaccinated at that time or to have standard care, to see if vaccinating women at that time reduces the chance of there being any recurrence. But we're waiting for the results of that. There is evidence from a Spanish study that says that it is a worthwhile thing to do. And again, on an individual basis, depending on your person's anxieties and whether or not they can afford it, it is available. But one has to be aware that within screening programs and within healthcare, we have to think of the benefit of the population and not a single individual. So that's when making those decisions. But the evidence is awaited.
Lovely, thank you. So I think you're second guessing the questions, because that's exactly what someone's asked about. Is the yearly smear test and HPV testing recommended for those who have colposcopy or had a LETS procedure? She was saying that she had a test of cure sample taken yesterday, 6 months post-treatment, and was told that if the cervical smear was negative, I'd be put onto normal recall, which is a 5-year recall at my age. So the study that
so just to say that post-treatment, regardless of your age, the normal recall is 3 years. So if you're 50, 55 and you've had treatment and your test of cure is negative, your recall will still be 3 years. It won't be 5.
That's really helpful. So the lady who's asking that question, I think you need to go back to them and tell them you need to be recalled at 3 years. So thank you very much. There's an enormous amount and lots of very complimentary comments coming in through the chat about how useful the information is and how delighted everyone is that we're talking about this. Now, there's a question here about how can we raise awareness in the workplace? I'd love to have a speaker attend one of our employee wellbeing lunch and learn type sessions. Do you have any recommendations? Well, I think we've got 2 people here, Maria and Hannah, who could possibly help with that. And I'm sure if you get in touch with the wellbeing team via our website, that they can give you some details. But do you think that is a useful way of going about it at the workplace, Hannah, and then Maria?
Yeah, I mean, we've got a time to test initiative at Joe's where employers can sign up with us to allow employees to go off and have their screening. So you can find out more about that, certainly. Can you just remind me the last part of that question? Sorry, Lesley. It was about
So they were wanting to know if they could
speaker.
access speakers, and I think actually Lena or Laura has already popped in there and given the questioner an address and said yes, we'd be delighted to discuss possibilities of collaboration.
You can also come to us at Joe's as well, because we often have people from our engagement team getting part and involved with that. So please do reach out to us as well if you'd like to.
And there's some very thoughtful questions here. So it's saying, as HPV is such an important prerequisite for cancer, does it carry its own symptoms to look out for? And if the symptoms for HPV are present, should we be pushing further for a smear test? So I think that's one of the problems, isn't it?
There's
HPV doesn't have a symptom.
No, there are no symptoms. So having it is just something one knows about if one checks for it. So another issue that we see in the last couple of years is that HPV as a primary screening test, as the first screen test that is done, has only been in place since 2020. So there's a whole group of women who have always had normal screen tests, normal cytology, normal smears, who have then attended since 2020 and find that they have HPV. And there's all sorts of things going on through their mind in terms of their relationships, in terms of them, and all sorts. But the issue is that they may have had that HPV for all their lives. We just never tested for it before. We didn't know. So so having it, as I mentioned, is there aren't any symptoms. It's common.
And that's a really important point, I think, to share with our audience, that actually, if you found to have it, it's not that something dramatic has happened recently, but if you hadn't been screened, and as Theresa was saying, you couldn't be before 2020, that's only 3 years ago, that it wouldn't be picked up. Now, there's another question that I wanted to make sure we didn't miss, because there was a lady saying that she was sharing with us that she was menopausal and had a sudden bleed a couple of weeks ago, which lasted for 4 days like a normal period. Should I see my GP about this? Well, I can answer that. I don't even have to go to the experts. Yes, you should. So any woman who has bleeding after 12 months of not having periods should go to the GP, and I'm sure that you will get a fast track referral to a rapid access clinic, because any bleeding after a year postmenopausally or post period stopping, we call postmenopausal bleeding. And we always have to assume that it's sinister or needs some action until we can prove otherwise. Now, the vast majority of women who come with postmenopausal bleeding won't have anything sinister going on, but that's the way to prevent serious things happening. So yes, please go to your GP and make sure that you're referred swiftly. Now, Maria, what thoughts did you have about the well-being, the question about, learning and sessions, and, for example, would your new screening tests be something that you would be able to publicize and talk to workplaces and employers in the future?
Absolutely. Sure. So we're only about to start with this fellowship, like in a couple of months, but I do believe that there are like quite a few ways of improving, like the knowledge around cervical screening, and also like improving the access and uptake for cervical screening. And I think this is like a very good idea to also have it in the workplace. First and foremost, I think that it's like quite critical for all women to firstly have an understanding of why they're being offered screening and what happens during the test, what are the benefits and the potential outcomes of this test. And therefore, I think there need to be concerted efforts and awareness campaigns, like highlighting the preventative benefits of screening. For instance, Joe's Cervical Cancer Trust and Wellbeing of Women, among others, can provide like numerous resources and webinars for raising awareness, such as the one we're doing today.
Lovely, thank you. And there's one other question which is very specific, so I think I'm just going to call it out. Some years ago, I was treated for cervical erosion and had cauterization. Does this have an effect on the future likelihood of getting HPV or cancer? So
interestingly, there was a study in the 50s where all women after having their baby were cauterized, or had their cervix cauterized, and they had very low rates of cervical cancer. So cervical cauterization probably has some sort of protective effect, but it's not something that one would necessarily in a modern age advise everybody to have. not
No,
without
I was
better
going to say,
evidence.
I'm just wondering what the ethics approval was for that, or whether they had any.
Well, it was a different time. I think there was one point that from the chat, but I've forgotten what I wanted to say. I think somebody was asking about if can they go to their GP if they're under 45 and ask for the HPV. Well, you can ask, but I don't think there's any obligation for GPs to provide it outside of teenagers. So I think it would need to be, you'd have to, do it on your own or privately. Superdrug, I believe you can buy it, or Boots perhaps.
Oh, really? Okay, you can go and buy it. I know when it was introduced, first introduced the HPV vaccine, my twin daughters, who are very grown up now, but they were just outside the catchment area, and I remember going off and purchasing the HPV vaccine and getting one of my colleagues actually here, Theresa Deirdre, vaccinated them for me. But I also remember how extraordinarily I got telephone calls from almost every mother of girls in this particular school year saying, "Oh dear, do you recommend this, or is it a bad thing to do?" And I thought, oh goodness, these were highly educated women. And I just thought, oh goodness, we've got so much to do, haven't we, to ensure that people understand the importance of these things. There's a lady here saying she's had a second colposcopy, biopsy and LETs this morning. My previous procedure was 30 years ago, but I had to chase, she says, today's appointment and copy the CEO of the trust into my communications because my positive sphere was in May 2022 and I heard nothing more via my GP. So she makes the comment there needs to be a much better campaign amongst GPs to take perimenopausal women seriously. And you heard what I was saying when the other lady who questioned she'd had a bleed. Yes, you must go straight away and you must be taken seriously. Any thoughts, Theresa, about how one can improve that sort of, if you like, the understanding amongst GPs and primary care with secondary care?
I think it's difficult and it's always a challenge because everybody is busy and there are so many competing things. And GPs are under a huge amount of pressure in reality because they have to be sort of the jack of all trades and pick up everything. But I think if you have a concern, then it's sensible to speak to your GP in the first instance. With respect to screening, when you attend for your screen test, if it's abnormal, we only now have one laboratory, for example, in London, and there are only 6 laboratories across the country. So when you have an abnormal screen test, the laboratory automatically contacts the colposcopy clinic. And so if the issue is an abnormal screen test, the laboratory will contact the colposcopy clinic and the colposcopy clinic should contact you for an appointment. And by and large, all women should be seen or offered an appointment, or most women, 93% within 6 weeks. The issue for some units, and indeed ours is one, is that we have huge capacity issues, and so therefore there may be delays in getting those appointments, and that is a problem that many of us are doing our best to address, but there just aren't enough nurses, doctors, people to offer the service that we need to offer. But that shouldn't stop you from seeking help, seeking advice if you have a query or a question.
And another query here, again about HPV. So does treatment refer to treatment of precancerous or cancerous cells, or do those with HPV also receive a treatment?
No, there's no treatment for having, so having HPV with no abnormality has no treatment. We only treat if there are abnormal cells, and even then we tend to be as conservative as we can be, and that's because the treatments that we do, particularly in women who are still wanting to have a family, there is evidence to show that in a proportion of those, they may go into labour slightly early if they have treatment. So, for example, we divide pre-malignant changes into what we call low grade and high grade, neither of which is cancer. If a woman has a low-grade abnormality, the likelihood is that over the next 3 years, that's going to go back to normal. So between 60 and 70% of women that have a low-grade change, it will go back to normal on its own without needing to do anything. So we don't rush and treat those. We want to see if nature will do its thing. For women who have a high-grade abnormality, we further subdivide that into, is it a moderate one or a severe one? So all women that have a severe change, which is not cancer, we do advise that those should be treated. In fairness, some of those women, even with a severe change, will not get cancer, but we have no mechanism. Perhaps Maria's study will make it easier for us, but currently we don't know if you have a severe change, whether you're going to get cancer if we don't do anything or not. So all of those women, we advise we should treat it, we should remove it so that we know you're not likely to get a problem. Interestingly, the group that is now slightly more complicated, if you like, is those women with a moderate change. And that's because 40% of them will go back to normal without doing anything, but 60% will either persist or may progress. So that's why those women may be called to have a further colposcopy examination more frequently, because we're wanting to monitor things. And equally, although we don't wish to treat, if a woman's family is complete, we're more likely to advise treatment because then the problem is solved. And if a woman is very anxious, so there may be a woman who says, well, I don't sleep at night anymore because I'm worried that this is here. So pragmatically, we may treat, even though clinically it may not be necessary. So women have choice, and women need to have time to have discussion. But broadly, low grade, don't treat, it's going to go away. High grade, probably treat to prevent cancer.
Lovely, that's really helpful. Thank you for that. And then we'll hope that Maria's research work will actually make your conundrum, or deciding who else needs treatment, much easier to resolve. Now, you mentioned women who've completed their families, Theresa, and perhaps you and Maria would like to make a comment, because there are, of course, concerns, aren't there? Well, there are risks to be balanced if a woman's having treatment, and perhaps to thinking about what might happen and whether it might have any effect on her reproductive outcomes in the future, specifically the pregnancy. So there's one of those questions is alluding to that here, I think. So that would be quite useful to hear about. And I think also, Theresa, you were saying that you had a few slides, weren't you, of what the treatment looks like. So I thought, well, while you're getting those up, perhaps I'll ask Maria and or Hannah, please feel free to chip in about what the potential implications are of having treatments or several treatments for cervix, and what happens to you in pregnancy later.
Hannah, would you like to go first?
Yes, so we do get lots of questions about this, and I think it's important to note that just because you've had treatment, it doesn't mean to say it is necessarily going to have implications on future pregnancies. We know that if you have everybody's cervix is different, so we know that where somebody might have treatment, theirs might be of a larger area than somebody else's. So our sort of support that we give at Joe's is to make sure your healthcare professionals know that you've had these treatments when you're or pregnant and assigned a midwife, because what they can do is ultrasound your cervix at a certain point during pregnancy to see if there's any need to have any further support there during the pregnancy. But it's not to say that you're definitely going to have problems just because you've had treatment. I think it's just about being aware of it and talking these things through with your healthcare professionals.
So putting it into pragmatic terms, if you've had quite a lot of tissue removed from the cervix, there is a possibility that it can weaken the cervix. Now, it's obviously very important to have treatment that's very thorough, but that's why it's so important to tell the midwife or the obstetrician, because it may be that you get shortening of the cervix, which of course leads to possibly a premature delivery. So it's not that it's going to damage the pregnancy, but we don't want babies to be delivered prematurely if we can avoid it. I remember when I was a junior obstetrician, I was always told that being born too early was the most dangerous thing that ever happens to a human being. And we still are very bad at predicting who's going to have a premature delivery. So that is really important to talk about. So it's not said to frighten you, just to make sure you're ahead of the curve and you can get the very best help you possibly can. Now, Theresa, you're going to show us a couple of those slides of the treatment, and I think that will be helpful. And as I say, more and more comments coming in saying thank you very much. It's so helpful, this. So thank you to all of our lovely guests and experts who are making this all seem so crystal clear.
Okay, so this is the most common treatment that so this is a video of the cervix, of the neck of the womb. This is giving local anesthetic to the cervix before doing the treatment. I think so you get the general idea. And then so this is putting on one of the solutions. So this is part of the colposcopy examination. And then in a moment, so we're going to use a there we go. So that's a loop wire. So that's you can see the cotton bud there. So that gives you an idea of the magnification. So the loop wire is heated because it's attached to something called the diathermy machine. And essentially what one is doing is removing the area where the abnormality is with a loop wire. This is done in clinic under a local anesthetic. And although that looks as if it's a fairly significant amount of tissue that's being removed, when one removes the tissue, as long as, particularly in younger women, if it's less than 1 centimetre in depth, then the evidence doesn't show a significant increase in preterm delivery. So so that is a LETS procedure. So that's an excision of the abnormal cells, and that's that was in real time. So you can see it's a fairly quick procedure once everything is done. And then I'm just gonna, if I can, show you another very common procedure. This is something called, well, in here it's called thermal coagulation, but it's a very common procedure, and it takes about, let me just see. So that we so you can see you're just putting a probe . So that's another common treatment. It's called cold coagulation or thermal coagulation, and has been shown to be very effective. Hasn't been shown to give the significant pregnancy morbidity, but it isn't suitable for everybody. So it's predominantly for a certain type of abnormality, and in younger women, so in women in whom we're trying to preserve their fertility, but it is very effective.
Thank you, that's great. Now, somebody is asking about what does cervical intraepithelial neoplasia mean? So I think I can answer that quite simply. It means that this is within the cells of the neck of the womb, and it's actually being contained within the cells. So these are why we're doing the colposcopy and doing the biopsy, to make sure that it hasn't, the cells, the abnormality in the cells hasn't gone through the wall of that cell, and therefore it's contained and can be treated in this way with local ablations rather than needing anything more dramatic. And then a very interesting question about, I have very large fibroids and I'm on the waiting list for a hysterectomy. If given the option, should I have a total hysterectomy or a subtotal one, in which the subtotal one means that they're leaving the cervix behind? Now, if I had £1 for every time someone had asked me this question, I'd be a very, very rich woman. So Hannah, you're smiling at me, so I'm going to ask you quickly to comment, and then Theresa, perhaps you'd like to comment too.
Yeah, I'm mainly because, again, we get asked this question a lot, and obviously it's down to sort of what your healthcare professional tells you is probably the best treatment option for you. But as Leslie's mentioned before, it is about, we do have a choice as a patient, and I suppose by having your cervix removed, then that is an area at the same time as having a hysterectomy that you haven't got to consider having smears moving forward. I don't know, Lesley, whether you want to. I was merely sort of, I suppose, smiling because this is something that we get asked, and it's good to be able to provide the support on another platform, I guess.
Theresa, do you want to make a comment?
Yes. So it depends on your point of view, and yes, truly, women do have choice, and so do clinicians, because sometimes it's just technically difficult to do and to perform a total hysterectomy if a woman has significantly large fibroids. However, I would say that the caveats are it is vital, mandatory even, I would go so far as to say that you are up to date with your cervical screen tests and you have never had an abnormality. So if there have been abnormal cells, if a woman has had treatment before, my advice would be, in terms of their safety and for the future, that it's better they have a total hysterectomy. If they have never had any abnormality, it's always been clear, then I think it depends. But also remember that if you leave your cervix, as Hannah says, you must still attend for regular cervical screening because you remain at risk. And it's also difficult because some GPs may not be aware. And the other thing that happens is a woman has a subtotal hysterectomy, and in the sort of Chinese whispers of the discharge summary, people forget that the cervix has been left. And that's the most potentially dangerous, because there's been a series of incidents in Scotland where exactly that has happened. There were a significant number of women in whom had a subtotal hysterectomy. People forgot or didn't realize, and so they were ceased from screening, and then they got cervical cancer. So yes, keep your cervix, but make sure it's screened and make sure it was normal before you go that way.
Absolutely, great advice. Thank you very much indeed. We've just got a few more moments, I think, before I'll be getting messages to wind things up. So let me turn to Maria, and we started right at the beginning about tips and advice for attending a smear test. Have you got any other thoughts about what we can offer our audience today? As I say, they're all very appreciative and keep saying in the chat that we've answered so many of their questions. So I think we've got that bit right. But anything else that you'd like to say, Maria, because your work is trying to focus down on the women that need to have the specialist treatment and to reassure the others. So anything you'd like to say about advice for attending the smear and what you see as going forward and the changes that might be possible for cervical lesions in the future?
Sure. So as I previously said, I think first of all, like raising awareness around the disease. But also, I think it's important to make sure that women with certain barriers, as Hannah said, like language barriers or underlying cultural barriers, are also given the same right of access to cervical screening. Now, another option that Theresa touched upon before that is currently under consideration is that women would be willing to be offered the choice of self-sampling. And only when this self-sample would come back positive for HPV, they would then need to have a sample collected by a clinician. And that happens in about 1 in 6 women. So there has been like a quite recent study at King's College London of more than 3,500 women, where the majority of those actually chose self-sampling in comparison to clinician sampling, with some of the reasons for this preference being ease or convenience or reduced embarrassment and increased comfort. And lastly, I think like uptake could also be improved by developing new technologies that would actually offer a bedside real-time screening test at one-stop clinics, because this would like provide an immediate result and also reduce the anxiety that is associated with the waiting time for the result to be back.
Thank you very much. So that I think is also very reassuring, and I hope that our audience today feel very reassured by all the expertise that we've had coming from different viewpoints, from a researcher, from a clinician on the front line, and from Joe's Cervical Cancer Trust. You see, everyone is trying to improve outcomes for women, do least treatments to achieve best outcome. But there's one question I must answer here. My mother died of cervical cancer. Can this be hereditary? And I think the answer is no. Am I correct, Theresa?
Yes, as I mentioned at the beginning, virtually all of us have HPV at some point, so there isn't anything to show that it's hereditary from that point of view. And can I just take the opportunity just to make two more comments? One is it's really important to get screened, because not being screened, particularly in this country, is your biggest risk of getting cervical cancer. So the people who aren't screened are the ones who are more likely to get it. So that in and of itself makes it important. And I think in the chat, somebody was talking about people who are transgender, non-binary. So any person that has a cervix is entitled to attend for cervical screening. So people who are transgender, it depends on what their sex was assigned at birth and what's on the GP register. But if you have any concerns and you need and want to be screened, if you speak to your GP, they may not, and you may feel that you don't want to be screened there, but they will refer you up again to one of our colposcopy clinics, and then we can make the arrangements. And for example, I have some people who are transgender who don't wish to be screened in clinic, and we can make arrangements for them to come in and have it done under sedation if necessary. So there's a range of things we can do so that every person with a cervix can be screened.
Lovely, thank you. And I know I've said this a couple of times, but there's so many appreciative comments coming through, including one saying, well, this is marvelous and I'm a healthcare professional. Can we get an hour CPD for this? So, wow, ladies, you have really, really done me proud here. Thank you so much. And then lastly, as I finish off, because I must do now, one of the audience have been saying so many women's health issues get so little media coverage. And it's understandable women don't see screening as a priority. It's another taboo subject. And that's why I want you all to go onto the Wellbeing of Women website and join us and join regularly to our webinars, which we have at least once a month, and get involved with our fundraising activities, because as I said, Wellbeing of Women is the only charity that funds research and education and advocacy, importantly, into every aspect of women's health from cradle to grave. So thank you to my marvelous panel. To Maria, we wish you great success with your work. Lots of people have commented in the chat that they're looking forward to hearing about the outcomes. To Hannah Dwyer from Joe's Cervical Cancer Trust. I seem to be meeting someone from Joe's Cervical Cancer Trust almost every day this week. So thank you for all you're doing in that sector and improving awareness. And Theresa, thank you. I mean, I must confess, Theresa and I are personal friends as well as colleagues, but I think the audience will agree with me. She's superbly knowledgeable about the things that she talks about, and very, very knowledgeable about cervical cancer. And I think it's been an enormously beneficial, this session. And I really do thank you all very, very much indeed. Make sure that you keep in contact with Wellbeing of Women, wellbeingofwomen.gov.uk. Thank you, and bye-bye. And thank you to Lena and to Laura and all of the WOW team for helping us have this seminar. Bye-bye.
Take care. Bye-bye.
Bye. Bye.